couple of minutes, I'll be talking about the management of acute liver failure, which itself is a huge topic, but I'll try to sum up the salient point. So I don't have anything to declare as a conflict of interest. So here is a case of 48 years old woman who presented to emergency with altered mental status over the last several hours. She was found by her husband earlier in a day to be acutely disoriented and increasingly somnolent. 2 days back, she has reported some symptoms like fatigue and nausea. And on examination, she was found ecteric, extractors were present. She was tender in right hypochondrium, and she was having grade 2 hepatic encephalopathy. So the initial labs which were sent to the emergency department revealed high transaminases, particularly ALT, high total bilirubin, and a high INR. So now the question for whenever you see such type of patient, and we do all see such patients in our routine practices. So the first question comes in our mind, that is this acute liver failure, or this is an acute hepatic decompensation, or this is an acute on chronic liver failure. So as we all know that acute liver failure is a rapid decline in hepatic function, which is actually characterized by the derangement in liver functions, manifested clinically by jaundice, and biochemically by elevation in enzymes as well as the coagulopathy, which experience over the period of like 12 weeks or less than 2 weeks, associated with the presence of altered mental status in a form of hepatic encephalopathy. And these are the all parameters we actually use to define acute liver failure. So when the patient comes to you, always look for these things, and especially the presence of any underlying disease which is known or not known. However, there is an exception, which is the patients with chronic autoimmune hepatitis, Wilson and Budd-Chiari syndrome, which could be considered as a case of acute liver failure. If they develop hepatic encephalopathy despite the presence of pre-existing liver disease, which was pretty stable or was not diagnosed in context to the appropriate abnormality in the liver function test and the coagulation profile, as I've mentioned before. So it is classified based upon the duration from the onset of jaundice to encephalopathy as an hyperacute, if it is actually manifesting within 7 days, as an acute one, if this is actually manifesting from the day 8 to day 28, or from the start of the second week up to the week 4, or a subacute one if it is actually ranging from 29 days to 12 days. So the term acute liver failure is preferred over the term fulminant hepatic failure, and this is how we use. And this classification, which is usually now followed, this is called as an O'Grady classification of acute liver failure. So is there any difference in their clinical manifestations? To answer is a little yes, there is some difference when they present, and this will actually help you to have some idea about the further course of the disease in the near future. For example, in case of hyperacute acute liver failure, these patients usually have more severe coagulopathy, and the degree of intracranial hypertension is like more marked over here. The chances of recovery, spontaneous recovery, are better in these cases, and most of such cases are because of either paracetamol-induced toxicity or viral hepatitis like hepatitis A and E. In case of acute liver failure, they have like coagulopathy, which is definitely severe, but less severe as compared to a hyperacute one. The jaundice is more marked. The degree of intracranial hypertension is also more marked, but these chances of spontaneous recovery is like moderate. In such cases, for examples, are because of chronic conditions like chronic hepatitis B, sometimes because of autoimmune hepatitis and all. In case of subacute one, the severity of coagulopathy is less, jaundice is more severe, intracranial hypertension may or may not be that marked, but the chances of spontaneous recovery is poor, and these cases is mostly because of non-paracetamol drug-induced injuries, and it includes many other causes. So whenever a patient is presenting to you, how can you assess them clinically and then laboratory wise? So always try to have some idea about that. What was when the jaundice was like observed or established? Try to identify the changes in their mental status, for example, the duration of confusion, slurring of speech, agitation, so that you can have an idea about that which degree of encephalopathy the patient is having. Explore about the constitutional symptoms coexisting. Medication history is again very important. For example, sometimes the patients are actually taking over-the-counter medications, and the medications being used. For example, somebody was having a fever, and this was because of a viral cause. But for fever, somebody has used paracetamol, and this cumulative paracetamol dose might be significant one. So the medication history in terms of toxicology, as well as like concomitant hepatic injury, is important. The history of travel and the previous history of seizure, developmental delay, liver disease, these are the things that actually can give you a clue about the etiology. The family history is again important. The physical findings is actually suggest that whether there is an underlying, are there any stigmata of underlying chronic liver disease is present or not? Because definitely this thing is actually also help you to have some idea about the course of the disease as well as the prognosis, and based upon that you can channelize your treatment for that particular patient. So we all know that these are the different etiologies which can actually lead to acute liver failure. So the distribution of these etiologies is actually different in the different areas of the world. For example, in the less developed countries, like for example in Asia, viral hepatitis is like considered as among the most common etiologies, especially hepatitis E in adults and hepatitis A in children. On the other hand, for example, country China and Japan, hepatitis B is a predominant cause. And on the other hand, in the Western population, paracetamol-induced acute liver failure, as well as alcohol-related acute liver failure is more predominant as compared to viral causes. So when you're assessing the patients clinically, again, you can get some idea from their presentation. And why I'm emphasizing again and again, because then you can actually start or consider the cause specific treatment while you are managing these patients. So in case of paracetamol related acute liver failure, these are the patients who have usually very high aminotransferase levels and relatively lower level of bilirubin, rapidly progressive disease, acidosis, and renal impairment right from the beginning. They do have, if this is a severe paracetamol-induced liver injury. Low phosphate may be seen as a good prognostic marker, but definitely the replacements will be needed. In case of non-paracetamol induced cases, subacute clinical course can mimic like the cirrhosis, especially when you do the radiological examination, and sometimes they also have ascites. In case of acute Budd-Chiari syndrome, abdominal pain, ascites, hepatomegaly, loss of hepatic venous signals, and reverse flow in the portal vein on an ultrasound, these are the main features where you can suspect it. And again, the time of presentation. For example, a pregnant lady presenting with ascites during a pregnancy, think about this cause. So in case of Wilson's disease, usually the patients are young and they may have a concomitant, for example, hemolysis. So if patient is young, patients are presenting with the neurological signs, hepatitis, hemolytic anemia, think about it. Mushroom poisoning, severe gastrointestinal symptoms after ingestion and development of early AKI. In case of autoimmune hepatitis, usually they have subacute presentations, and usually the patient may have some concomitant symptoms, maybe a history of joint pains, skin rash, and all. In case of malignant infiltration, definitely but the picture will be a little different. Again, this type of demarcation, while the patient is presenting and trying to get some idea about an etiology, will also not only help you to have an idea about the disease course and the specific treatment for that disease, but also will give you some idea about the liver transplantation as well. For example, the patients with all of these categories, they could be considered as a better candidate for liver transplantation as compared to those who will be presenting with malignant infiltration. So remember, when you are assessing this patient, um, on each and every step, you will be assessing them in terms of current management, their further disease course in the future, possible treatment you can provide them, prognosis, and the possibility of their candidacy as a liver transplant candidate. Because definitely the disease rapidly progress, you won't have much time. So you need to actually think, assess, and plan accordingly very quickly. So make sure that your patient is being cared at a proper setting. For example, if the patient is having grade 3 or 4 encephalopathy, should be going to an ICU. Ideally, all patients should be in ICU, but definitely ICU beds are limited. So patients with grade 1 or grade 2 encephalopathy, they can be managed in high dependency unit. For example, the hospital facilities where the special care units are available, they can be treated over there, but with a high, keeping this in mind that they may require intubation at any point in time in an ICU care. So when they're presenting, so to assess the disease severity, these are the tests you can do, and the serial monitoring of prognostic factor. For example, the prothrombin time will also be needed. Arterial blood gases and lactate level, they will give you an idea about the further worsening and all. So the test to evaluate for underlying etiology is important. You can customize, or you can tailor the selection of tests based upon your clinical assessment, and definitely sending all of these tests right away may not be cost effective for a country like Pakistan, but definitely based upon a good history, you can send them the common etiological factor or a specific test, for example, in autoimmune hepatitis or Wilson's, if there are some clinical clue. So the test for the complications, for example, the amylase lipase, as well as the X-ray chest and ECG, if needed, these things could be done. Try to evaluate them for a presence of underlying cirrhosis, which may not be identified earlier. In certain cases where there will be the liver biopsy will be needed, but definitely these are the selective cases. For example, when you are suspecting an autoimmune hepatitis or a Wilson's disease, something like that. So whenever you think that there is a need for liver biopsy, the transjugular liver biopsy is considered better as compared to transabdominal liver biopsy. So as I said, that associated test, for example, to identify whether there is an ongoing infection in a chest or not, ECG could be done. So monitor them, their vitals, urine output, neurological status, avoid sedative, take care of their hypoglycemia issues and all. So these are the potential complications of acute liver failure these patients develop. For example, the hemodynamic instability, they're prone for arrhythmias, they're prone for infection, especially the bacterial and fungal infection. So the coagulation disorder and hemostasis disorders are quite common. They do develop the pulmonary complications, acute respiratory distress syndrome, and fluid overload. The CNS the CNS complication, for example, cerebral edema manifested in a form of encephalopathy, metabolic derangement, and the renal function. These are the potential organ-related complication these patients can manifest. So how about hemodynamic management? So these patients, due to low systemic vascular resistance, and sometimes they are intravascular volume depleted, they do have hemodynamic instability. So you can resuscitate them with the help of crystalloids like normal saline. If they are acidotic, then you can combine half saline with sodium bicarbonate. If they're getting hypoglycemic, then the dextrose should be added to the crystalloid solution if the patient is having hypoglycemia. And if somebody is having a persistent hypoglycemia, then you can add 10% dextrose as well. So if the patient requires vasopressor support, so then you can use norepinephrine, which is considered better. But if norepinephrine is patient is not responding to that, then you can add vasopressin. And if someone is actually having a persistent hypotension, you remember these patients are prone for hypoadrenal insufficiency. Here you can give them a trial of steroid. So hyperkalemia, hyponatremia, hypophosphatemia, potassium electrolyte imbalances, all of these metabolic abnormalities these patients are prone for. So you need to check them periodically and correct them if they are present. Lactate elevation is related to increased production and decreased clearance, and it remains a poor prognostic marker. And if there is severe lactic acidosis, then RRT is indicated to correct acidosis and other metabolic disturbance. So the coagulation disturbance is pretty common, but the prophylactic administration of FFP is not recommended because it doesn't have any influence on mortality. It can interfere with the assessment of liver function and may lead to fluid overload. So if somebody is anemic, then the target hemoglobin is like around 7. If less than that, then you can transfuse them. And as they are coagulopathic, and the most common site for these patients are GI tract, stress-induced ulcers, and precipitated by the coagulopathy. So the prophylaxis with PPI or H2 receptor blocker could be provided to these patients. So the infections, the risk of infection is quite high. So the most common site of infections are respiratory tract infection, UTI, septicemia, and remember that they have the tendency for the fungal infections. So the suspicion for fungal infection should be low, and early identification always helps the patient. So remember that many times the localizing signs of infection, for example, fever, sputum production, these are absent, and the only clue for the ongoing infection is maybe the worsening of encephalopathy or renal function or an overall deterioration. So the prophylactic, so the culture should be done for such patients, especially if they are deteriorating. So the role of prophylactic antibiotic is controversial, and most of the authorities suggested that give antibiotic broader spectrum if there is evidence of ongoing infection, positive surveillance culture results, or clinical deterioration. Hepatic encephalopathy is a major problem for such patients, and this could be managed with the help of medication. We have to clear ammonia, including rifaximin, lactulose, and all. And some supportive treatment is also needed for such patient. For example, the surrounding should be quiet. You can elevate the head, and the role of hypothermia is plus minus. And again, if the patient is progressing to grade 3 or more than that, then better to intubate them, ventilate, and sedate if they have grade 3 or grade 4 encephalopathy. And this is to protect the airway, prevent an aspiration, and provide a safe respiratory care. So definitely the target PCO2 levels are defined. If you need to sedate them, you can use propofol. And in case of seizures activity, monitoring with EEG and relatively better, less hepatotoxic anti-epileptic drugs could be added if needed. So the nutrition is a vital component, and this is one aspect often we ignore. This is a high catabolic condition, and here the patient require high calorie diet, and so that the calorie count could be maintained. And this is also required to prevent catabolism of body stores of protein, because if you'll be providing low caloric diet, the body will be using proteins and the fats, and that will be a problem for the patient. A daily intake of 60 gram of protein is reasonable. Oral, if this is grade 1 encephalopathy, diet could be given, or enteral feeding could be given. Placement of NG tube can increase an IC, raise intracranial pressure because of gagging, and should generally be performed only in patients who are intubated or sedated. If adequate enteral feeding cannot be provided, then the parenteral nutrition could be provided to them. Invasive airway management is required in the phase of progression of high grade hepatic encephalopathy, grade 3 to 4. And many of them, they do have acute kidney injury and metabolic acidosis. And here you can provide them RRT. Remember the medication to be avoided, including hepatotoxic drug like paracetamol and others. Sedation ideally should be avoided. But if you need to give them, for example, the patient is very, very agitated, then the short-acting benzodiazepine could be given. If you need to sedate them, for example, on the ventilator, then propofol can be given. And these are the preferable medication over opioid. The next come to the specific treatment of an underlying cause. So we all know that if somebody is having an acetaminophen toxicity, N-acetylcysteine is the drug which improves the prognosis, and the threshold to give it is actually should be low, especially not only in patients who are having acetaminophen induced toxicity, but now it's recommended that the patient who haven't used the toxic dose, relatively lower doses, it may be toxic dose for that person. For example, somebody is using alcohol on a regular basis, relatively lower dose could be a toxic one. So by giving a benefit of doubt, you can give an acetylcysteine to the patient even on the lower dose. So what about those patients who doesn't have any history of acetaminophen induced toxicity? Though the data is limited, but it's still there is an evidence available that it is reasonable to give it to the patient who are not candidate for liver transplantation and to the patient who in whom acetaminophen toxicity may be contributed to the liver failure, even if the lower doses received by the patient. So there was a placebo-controlled trial involving 173 patients with ALF due to the causes other than acetaminophen, and it included the patients who have drug-induced liver injury other than acetaminophen, autoimmune hepatitis, hepatitis B, and other causes. And here, the acetaminophen, N-acetylcysteine was given in a form of infusion, which showed some good difference in transplant-free survival in between the two groups. And you remember the largest trial, which was done by Professor William Lee, LF group in USA, and there they have used it in patients without acetaminophen-induced toxicity and found was reported to be having a beneficial effect. So for hepatitis B, the role of antiviral therapy, it could be considered, though it hasn't been proven to have a big impact, but it can actually improve post-transplant outcome in such patients, so it could be considered. So for acute Budd-Chiari syndrome, method to restore hepatic drainage, including TIPS, surgical decompression, or thrombolysis could be considered based upon, depending upon the situation. So in case of autoimmune hepatitis, corticosteroid had not been convincingly shown to improve outcome, but a trial of corticosteroid could be administered to the patient with low-grade hepatic encephalopathy and only but for a time period. But if the patient is not getting better within the 7 days, these patients could be considered for liver transplantation. If there is an evidence herpes simplex infection, acyclovir could be given for patients with Wilson's disease. Typically, they require liver transplantation. There is no good role of chelation therapy. However, the plasma exchange to remove the copper may act as a temporizing measure. The dialysis and all doesn't show any much significant role, though they can actually remove some amount of the copper. So the pregnancy liver related condition, for example, HELP and acute fatty liver of the pregnancy, prompt delivery can improve your patient outcome. Mushroom poisoning, early administration of activated charcoal is recommended. So the liver transplantation is the modality of the treatment which is actually has shown a revolutionary role in the management of acute liver failure. And 1 year survival following the emergency liver transplantation is now around 80%. The selection is important. It all depends on the accurate prediction of transplant, the prediction of survival without transplantation, and then whether the patient is a good candidate for this or not. So when the patient is actually coming to you right from the beginning, you need to assess if the liver transplantation is not available in your center. It is better to predict that the patient is whether the patient is getting deteriorated and all, and it's better to shift early to the transplant center rather than shifting them late when doing a transplantation for such sick patient may not be an option even in the best center. So the different criterias are actually being used and evaluated. The most famous and widely accepted one is the King's College criteria and the clicky criteria. And these are the differences in the sensitivities and specificities of these different criteria has been used, and it's still the King's College criteria is like the most widely used one. So what about the role of artificial and bioartificial liver devices? These are intended to provide a bridge to the transplant or recovery of the liver function, reducing the need for the transplantation. Experience with liver support devices to date has been not that wasn't found that beneficial, but it can be used as a bridge therapy. So, ladies and gentlemen, in summary, acute liver failure has a high mortality, early recognition, and broad investigation for etiologies are required. Timely medical management could actually improve the survival and to avoid the need of liver transplantation. Extrahepatic organ failure is common, and all patients should be discussed with the local critical care team as well as with the regional liver transplant centers.